This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME accredited course for advanced practitioners and physicians. My name is Peter Sloan, and I am one of the course directors for Cardiology Academy. I would like to introduce our speaker, Dr. Nimesh Shah, who is currently the medical director of the cardiovascular ICU at MedStar Union Memorial Hospital in Baltimore, Maryland, who will provide an overview of the intra-aortic balloon pump.
Discuss intra-aortic balloon pumps. This is a ubiquitous technology that's available in most cardiovascular ICUs. It can be inserted into the patient before, during, or after heart surgery. It has the benefit of providing a mild increase in cardiac output, but really it is used for improving coronary artery perfusion or reducing myocardial oxygen demand, as we'll discuss in the next slides. A helium-filled balloon is typically inserted from the femoral artery and advanced towards the descending thoracic aorta, with the tip ending just below the left subclavian artery. During diastole, the balloon inflates, which causes displacement of blood above the balloon towards the head as well as the coronary arteries, and below the balloon towards the legs. During late diastole, the helium-filled balloon deflates, creating a low afterload environment for the left ventricle to eject into, ultimately reducing myocardial oxygen consumption. On the right side, you can see a fluoroscopic image of an intra-aortic balloon pump with both inflation and deflation. You can see the tip is located just below the aortic knob and the carina. Cannulation for intra-aortic balloon pump typically occurs through a sheath, roughly 7 to 8 French size, that's inserted into the common femoral artery below the inguinal ligament but above the bifurcation. As you can see in this illustration, that is the perfect location because it is above the bone of the femoral head. When the catheter and sheath are removed, it allows for a firm surface for pressure and hemostasis. It's important for the ICU provider to keep in mind the location of insertion. A high or a low stick can often lead to bleeding complications in the ICU. This is an example of an ultrasound image for procedural planning to place an intra-aortic balloon pump at the bedside. The proceduralist is looking for the ideal location to insert the femoral sheath above the bifurcation of the aorta and below the inguinal ligament. View the cardiac physiology to remind ourselves on how the balloon coordinates inflation and deflation. On the top right, you can see the ECG tracing. You can see that systole begins at the QRS complex, while diastole begins at the T wave. On the second graph, the aortic pressure, there is a dichrotic notch that represents the end of systole when the aortic valve is closing and the beginning of diastole. This is the pressure point at which the intra-aortic balloon pump inflates. Let's review the display of an intra-aortic balloon pump. In this image on the top row, you can see the patient is in normal sinus rhythm, roughly 96 beats per minute. On the second row, in red, you can see the pressure waveforms, which we'll get back to in a minute. And on the bottom row, you can see that every other beat, the balloon is being inflated with helium, and is producing an augmented pressure of 114 millimeters of mercury with each filling of the balloon. Now let's go back to the second row, the pressure tracing. As you can see, every other beat there is increased pressure right after the dicritic notch, and there is a deflation just below the next systolic waveform. On the right side, you can see the the mean blood pressure is 81 millimeters of mercury, and the blood pressure is 80 over 66. This does not include the augmented pressure from the balloon pump, which is providing pressure of 114 millimeters of mercury. Let's discuss how the augmented pressure during diastole improves coronary artery blood flow. On the right side, you can see that most of the coronary artery blood flow occurs during diastole. Thus, if there's more pressure in the aorta, there should be more blood flow into the coronary arteries, particularly if there is partially blocked blood vessels due to plaque or calcium. Getting more blood to the areas distal to the blockage, intra-aortic balloon pump will help increase that perfusion pressure. Now let's review the pressure tracings in a little bit more detail. Here on the left arrow, you can see that there is no augmentation of the aortic tracing, neither in diastole or before systole. Here on the left side, there is a diastolic augmentation right after the dicritic notch, with a deflation occurring just before systole of the next aortic tracing. Notice how the trough before that next systolic aortic tracing is lower than the unassisted aortic tracing. This lower blood pressure provides reduced afterload to the left ventricle. The position of the intra-aortic balloon pump requires careful monitoring in the ICU. On the left side, you can see a radiopaque marker, the proximal tip of the intra-aortic balloon pump that is typically located just below the aortic knob and roughly around the carina. This can often move and migrate with patient transportation or movement, and often requires frequent chest x-rays to make sure the positioning has not changed. On the right side, you can see the intra-aortic balloon pump has been slightly withdrawn into the mid part of the descending thoracic aorta. In this patient, it should be advanced using proper techniques. There's a risk for visceral malperfusion related to the balloon pump occluding visceral vessels.
If you'd like to learn more, please visit our educational center at pulmonaryandSleepAcademy.com, where we have 70 hours of self-paced online CME accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.